I think it's last. Hi, welcome to Strasburg Sessions here. We're going to be doing these talks the first Monday of every month going forward. So we have some great topics coming to you about different health topics, metabolic syndrome, hormones, cardiovascular health, gluten-free holidays, a bunch of cool stuff. So I'm starting it off. I'm Dr. Christa Whiteman. I'm the chiropractor and one of the chiropractor functional medicine docs here in Strasburg. I'm here 5 days a week, seeing chiro patients, doing functional medicine. I joined the practice here in 2023. I had a practice of my own up in New York for 16 years. And it's sort of coming full circle for me to come work here at Turnpaugh Health. My mom has been a patient of Dr. Turnpaugh's for 17 years. And she basically sought help from him for her hypothyroid, her celiac disease, which is an autoimmune disease. And he helped her, introduced her to functional medicine, is how I got introduced to functional medicine. And so here I am 17 years later working for Dr. Turnpaugh and getting to help my patients in the same way that he helped my mom many years ago. So very cool thing that I get to do here. So I'm here tonight talking about hormones, and I'll talk a bit about perimenopause as well too. So to start with though, to make it a little bit more interesting, I want to introduce you to Molly. And Molly is a composite of some of my patients that I work with. The asterisk is because I have no patient named Molly, so this is not actually representative of anybody named Molly. She, like I said, is a composite of a bunch of different patients. She's somewhere between maybe her mid-30s to mid-40s. She's a busy mom. She's tired all the time, despite the fact that she gets 8 hours of sleep in. She wakes up in the morning, still tired. She tries to eat well. She tries to exercise, but it's hard. She's tired. She still has kids that she's got to take care of. She still is getting some of this stubborn weight gain. A lot of times she comes to me and she's like, I just can't lose this last 5-10 pounds. I'm watching what I eat. I'm exercising, and just nothing is really happening. It's getting very frustrating. She's moody, and she's telling me, like, I usually like my husband, but some days I really question whether or not I still do. The kids are annoying me all the time. I feel more likely to be depressed. Sometimes I'm anxious. I just feel really irritable and on edge all the time. Because of her age, she's getting targeted on social media by a bunch of things telling her her hormones are off, she needs this cream, she needs this surgery, she needs this supplement, etc., etc. And she's probably tried some things and just like nothing's working. And she's like, how do I feel better and get some of this extra weight off me? I want to have more energy. I want to feel like I used to. Help kind of thing. So that's Molly, and I'm going to be talking a little bit about hormones through the lens of Molly, right, and bringing that back to her at various points. So Molly comes into my office, and one of the first things, here's how I'm kind of thinking about how do I work with Molly, right? This is the endocrine system, obviously, because it says endocrine system at the top. But I wanted to put this in here because I'm going to kind of run through, this isn't exhaustive, but we're going to look at the top part of this is the hypothalamus and the pituitary gland. The hypothalamus is like your thermostat. It is constantly sensing what's going on with different levels of things in your body, and then talking to the pituitary gland and telling it how to carry out adjustments to what's going on. So if the hypothalamus is sensing that there's not enough thyroxine, T4 hormone in the body, it says, okay, we need to turn that up a little bit. So it tells the pituitary to secrete some more TSH, thyroid stimulating hormone, and that goes down, talks to the thyroid gland, turns up the production of T4, all right? Similar things are happening we have an axis that goes from the hypothalamus and the pituitary to each one of these glands, right? So that talks down to the thyroid, talks down to the adrenals, it talks down to the ovaries or the gonads. We're also going to talk, so we have the hypothalamus pituitary thyroid axis, we have the hypothalamus pituitary adrenal axis, so HPT axis, HPA axis, and the HPG axis, G for gonads, because it depends on whether or not you have ovaries or you have testes. I also put this in here so you can see this sort of hierarchical level to them. And this is like how I'm going to think about working through Molly's issues about her fatigue, her weight gain. It could be coming from a couple of different hormones. So to not get sucked into a hole and have blinders on and just go to the ovaries and the estrogen and the progesterone just because of her age, I want to make sure that everything is working across Molly's endocrine system so it all works together properly. All right, so I'm going to work kind of methodically through these axes to make sure that she's going to feel her best after we're working with her. All right, so I'm going to start with her thyroid, primarily because every cell in the body has a receptor for thyroid hormone. So that thyroid hormone has the ability to actually go into the cell and affect how fast DNA is read and how fast the enzymes are made from that DNA. Those enzymes are what control metabolism. So people are saying, oh, my metabolism feels like it just hit the skids when I turned 40. Okay, well, is your thyroid acting properly? Do you have enough hormone that's going in there? Okay. So TSH is talking down from the pituitary gland. It's telling the thyroid to make T4, and then T4 gets converted to T3. That's the actual active hormone. T4 to T3, that conversion is impacted by inflammation. Does anybody here think you might have some inflammation happening? Okay? So I put that in here because it's really important. Molly might come to me and she might say, I had a TSH test done. My doctor did it. My TSH is normal. My thyroid is fine. And I'm going to have to ask Molly, are we sure? Did we check all of the thyroid? Did we check your T4? Did we check your T3? Because Molly could have a normal TSH and a normal T4 and not be converting to T3 and still have hypothyroid symptoms even though her TSH is normal. Okay, so some of the things that Molly might have if she has a hypothyroid, she's going to tell me like, oh, I just kind of, my mood's low, I feel like a little bit like an Eeyore, a little tendency towards depression. I might have some brain fog, I can't think quite straight. Weight gain, she might tell me she feels like she's losing her hair a little bit more than she normally would. She might tell me that her bowels are slower, she feels a more tendency towards constipation, she's cold all the time, especially in her hands and her feet. And I'm thinking, okay, we definitely need to check Molly's thyroid, even if her doc said it's okay, it's normal with her TSH, okay? The other thing that I wanted to bring up about thyroid hormone here is thyroid replacement hormone is the third most prescribed medication in the United States. So there's a lot of folks who are on replacement thyroid hormone. And by the time I see a woman who's in her 40s, she probably, statistically, is on thyroid hormone. So as we're getting her prepared to go through menopause and perimenopause and menopause and thinking about her postmenopausal life, one of, course, the things that we're thinking is bone health, right? Preventing osteoporosis. And it's not just making sure she has enough estrogen to keep good bone mass, but if her thyroid medication, if she's over-medicated with her thyroid medication, she could be more prone to osteoporosis. That thyroid medication, by speeding up her, increasing her T4, can also increase the cells that break down bone, something called the osteoclasts. So we have osteoblasts and osteoclasts that are building up our bone and breaking down our bone. And so if the osteoclasts that break it down are turned up too high, we might end up with less dense bones because of that. So I want to make sure that as I'm working with Molly for her future self, that if she's on thyroid medication, we're in a good zone for her that helps her feel better, but isn't also potentially putting her future skeletal health at risk. All right, so that's thinking about how's Molly's thyroid functioning. And then I'm going to come down next to what's happening at the pancreas level with insulin with Molly. Does she have insulin resistance? So most of us, we kind of know, right, that most of us have too much sugar in our diet these days, more than we used to. So that means as we get older, there's more of a prevalence of insulin resistance. And insulin resistance is also known as prediabetes. It's before we actually get to diabetes. And what happens is if the glucose or the blood sugar is high for a while, we need insulin to help drive that glucose into the cell. And the cells can end up being like that, you know, that closet you have at your house that you keep putting everything into when people come over, and pretty soon there's no room, you can't close the door, okay? So if our cells are getting too much glucose into them, eventually they're like, enough, I can't make enough, I can't do anything with this, I'm full up. So they'll decrease the number of receptors they have for insulin to act on the surface of the cell, okay? That's what we mean by insulin resistance. Now if I had 4 doors for that blood glucose to go in, now maybe I only have 2. And that leads to 2 different things happening. One, the glucose builds up in the blood, and we have higher levels of glucose. And our bodies are thrifty, they're smart, they're not like, oh, we'll just let that go, we'll just pee it out or get rid of it in feces. They're like, I will save that for later, because I don't know if I'm gonna always have another meal, maybe something might happen, a family might come. And so our bodies are like, oh, I'll just take that extra glucose and I'll just pack it away for a rainy day in the adipose tissue, right? But because we have easy access to calories all the time, the rainy day never comes. We never kind of go into that. I call our fat tissue our savings account. So some of us are really good savers, right? And that's not a terrible thing, except we never spend down the savings, right? So that is partially another reason why she may have some weight gain, especially kind of around her middle, is if her insulin is not being able to act on the cells properly. We have some insulin resistance, we're getting all that extra energy put towards the adipose tissue instead of going into the cells. And then corollary to that, now the cells aren't getting enough blood glucose, they're not getting enough glucose that they need to make energy, and so the cells start to say and send signals like, I'm hungry, I'm not getting enough, right? And so she might feel tired and fatigued, paradoxically, because inside the cell there's not enough energy coming in to run metabolism, whereas we have a caloric access on the outside of the cell. So that's driven by insulin resistance, okay? And that increase in insulin and blood glucose can have implications for future cardiovascular health. It can increase blood pressure. So we definitely want to deal with this sooner rather than later, especially to prevent diabetes if this is happening with Molly, all right? Also, if we're going to help her maybe lose a little bit of weight, feel a little bit more energy, it's going to be really hard for me to help her feel that way if I can't get fuel into her cells to make energy, right? Another important thing to keep in mind, too, about insulin as it affects our sex hormones, testosterone, estrogen, progesterone, insulin has the ability in men, it can upregulate an enzyme that will take their testosterone and convert it into estrogen. And that is something that can drive andropause, it can drive low testosterone, muscle loss, fatigue, low libido, erectile dysfunction in men. In women, it can do the opposite, where high insulin levels may cause an enzyme to convert estrogen into testosterone. And now that woman has slightly more testosterone than what she should. So she might have irregular periods, she may have infertility. If the testosterone is high enough, she might actually start to grow hair in some places that she doesn't want to necessarily grow hair. Those women I usually see a little bit younger because they're struggling with fertility, right? So going back to Molly, she has a couple of kids. I'm maybe not quite as worried about that presentation with her. That's something that we call PCOS, or polycystic ovarian syndrome, where her insulin is high, she has insulin resistance, causing her testosterone levels to be relatively elevated in comparison to her estrogen levels. So I might not be as worried about that with Molly, but I still want to make sure we're not dealing with insulin resistance, as it might be blocking her ability to make good energy, utilize her macronutrients as efficiently. Alright, and the next one I wanted to throw in here is cortisol, primarily because it comes from the adrenal glands, which are kind of sitting there like little top hat glands on top of our kidneys. Cortisol gets a bad rap because it's our stress hormone, but it does a lot more for us besides that. It does help mobilize sugar, blood sugar, and help us utilize it a little bit more. It does have the ability to suppress our immune system a little bit, which is why we tend to get sick more often when we're under stress. But sometimes we need that in order to keep our immune system from going too haywire. But if I'm working with Molly and I'm seeing some things indicating some adrenal stress and too much cortisol, I might have a question about what's her immune system going on? What's going on there? Is there an autoimmune disease that her body is trying to quell an inflammatory response with an increased amount of cortisol? Alright. Cortisol also has a circadian rhythm. That means it should be high first thing in the morning. This is the hormone that kind of gets you up out of bed. I tell my patients that this is like your body's natural caffeine. When your cortisol is waking up, or in the first thing in the morning, you're like waking up and getting ready for your day, you're more attentive, etc. Throughout the day, it slopes down to its lowest point, which is right before bed, okay? If Molly has a change in her cortisol rhythm, where her cortisol is maybe higher towards the end of the day, or it comes back up at the end of the day, she might not sleep very well. She might go to lay in bed and she's just like, I'm awake, I can't wake up, right? Or I can't go to sleep. So she's coming to me telling me she's tired all the time. Well, do you sleep okay? You know, she says she sleeps 8 hours, but then she wakes up and she doesn't feel refreshed. Did her hormones let her sleep properly, or did they not? Well, did she actually get restorative sleep, or is there something happening with that cortisol rhythm that's keeping her from getting that deep restorative sleep that she actually needs to feel better? Because cortisol is secreted from the adrenal glands, it can have implications. If there's irregularities in what's happening with cortisol, there can be implications for what happens to some of the other hormones that the adrenal glands secrete. One of those is aldosterone. Aldosterone helps us manage our blood pressure. So it helps us hold on to sodium, which means we hold on to water. That's one of the reasons why the whole cortisol face, if you've seen it on social media and stuff like that, that puffiness first thing in the morning, that's that retained water that may be happening. Something at the bottom here too in regards to how cortisol may affect our other hormone balance is something called pregnenolone steal. So I want to make sure this is not happening to you, Molly. So here's my hormone flow chart. I know for the back you probably can't see it, okay? Here's the main things to know. One is this is several different hormones over here, but look how they all have the same ring formation, okay? They're all steroid hormones. That is what vitamin D looks like, more or less, with a couple functional groups changed. So all of these things really get made from vitamin D. The vitamin D, I had to write it in because this flow chart didn't have it in here. But that vitamin D3 goes through a couple changes, gets made into cholesterol, that goes through a couple changes, and the cholesterol gets made into this thing called pregnenolone. And then from here, you can hopefully see these two branches, these two arms. On the one side is progesterone, and then cortisol below that. On the other side is DHEA, which is an adrenal hormone, and it is making our androgens, androstenedione and androstenediol, which is making testosterone, and here's estradiol down here, okay? So pregnenolone steal is basically when all of this gets shunted this way into cortisol. And we're under so much stress, we have such a load for making cortisol that we take all of that pregnenolone and make it into cortisol, and so we basically tank estradiol and androgen levels because it's all going and being shunted this way. Alright, so if I'm talking with Molly and she's telling me she's under a lot of stress, maybe there's a big thing happening at her job, and maybe her husband and her have been fighting a whole heck of a lot, or maybe something's going on with kids, I'm going to go, well, before we do any like hormone replacement, do we need to check that it's not going to all end up here if we try and put some more hormone in here? Alright. So, again, coming back to Molly, before we even got into measuring her estrogen or her progesterone or her other hormones, we've had to ask, are these tissues are they able to make enough of the estrogen progesterone? And that is going to be influenced by, can enough thyroid hormone actually get into the cell and tell those cells, make them make the enzymes they need to make her hormones, right? If she's not getting enough of that thyroid in there, maybe her body can't make enough of its own, right? Are the cells that make these hormones, do they have enough energy to do so? Is their energy getting blocked because of insulin resistance? And so now these cells, like, they just can't get enough glucose into them to make ATP, the energy currency of the cell, to make the enzymes work that pop out for relative levels of estrogen and progesterone. Do we even have the right nutrient levels in place to make adequate levels of these hormones? Is she getting enough vitamin D? I can't tell you how many women come to me and they're like, I would like to have my hormones checked. And I'm like, okay, well, we should also check your vitamin D. And their vitamin D is like 17. I'm like, let's start with your vitamin D before we do a whole bunch of other things. Vitamin D should be a minimum of 30. Here we say between 60 and 80 for optimal health. 17 is pretty low. I'm like, what are you supposed to do with that? 17, your body's going to have to choose what it's going to do with that vitamin D if you've got that little vitamin D. Are the other hormones taking resources away from making adequate levels of these hormones? Is she having that pregnenolone steal? Is it going to something else? Is it being shuttled down a different pathway instead of where it needs to go to make the relative levels of estrogen and progesterone that she needs? Alright, so once we've checked all that, alright, because we're here doing holistic medicine, right? I'm going to spend time with Molly. I'm going to ask her lots of questions about what's going on in her life, how she's sleeping, what her energy's like, what her digestion is like, what her diet's like, what aches and pains she has, all kinds of things, right? I want to get the full picture because we're here trying to get to root causes. I'm not just trying to slap band-aids on stuff and just like, oh, you're 48, here's your HRT, see you later, kind of type thing. We want to get to, if we're going to use that, we want to make it the most effective strategy that we can so Molly can feel her best, right? So I want to make sure that I'm working through this whole endocrine system in a very methodical kind of way. So now that I've done that, we can start to ask about estrogen, progesterone, etc. I also do that, just as an aside, when I am working with a woman who is still cycling and we want to check her hormones. There's a window between day 19 and day 21 of her cycle where the hormones are kind of all relative to each other in a sort of known ratio. And so that's when I usually like to check her baseline hormones between day 19 and 21 per cycle. So usually she doesn't know that when she comes to me. So the first thing I'll do is like, oh, okay, it's day 6 of your cycle. Well, let's check your thyroid, your insulin, your cortisol, your vitamin D, and then we'll come back between day 19 and 21, we'll grab your estrogen, your progesterone, your FSH, your LH, your other hormones. So, do we all know that there's several types of estrogen, right? So there's E1, E2, E3. When we're talking about estrogen, generally what we mean is estradiol, that's E2. That's the main one that does all the things we really think of estrogen doing. It's not just a hormone for menstruation and ovulation. It's a hormone that we use. It supports brain health, it supports bone health, it supports cardiovascular health, even after menopause. So there's sort of this pervasive, and has been for a long time, that because all women go through menopause, it's normal to have no hormones after menopause. To a certain extent, that's true. You have way less hormones than you do when you're menstruating, but that doesn't mean you need zero, right? For a woman's health and longevity, she needs still some hormone, right? And we'll cross that in a little bit where that comes from. So proper levels of estradiol will increase bone density and decrease bone reabsorption. That's that osteoclast activity we already talked about. It'll improve her metabolic rate and insulin sensitivity. Helps improve her cholesterol by lowering problematic LDL-C levels, lowering homocysteine, which is an inflammatory marker in the cardiovascular system. It supports endothelial elasticity. That means how elastic the inside of the vessels are, which we want to be able to absorb the pressures from the heart. When they get stiff and gunked up with calcium or cholesterol, that's when we have atherosclerosis or cardiovascular disease. So we want nice elasticity and stretchiness, flexibility in that endothelial lining of the cardiovascular system, and collagen synthesis, right? Which is why you may see estrogen in topical face serums for women, that as they start to lose some of their estrogen, we might lose some of the elasticity and the softness in the collagen in our skin, and so it starts to look more aged and have more fine lines, wrinkles, etc. Right? It helps improve memory and concentration. All right. so increases serotonin and activates serotonin receptors. So our brains need some estrogen. So Molly, if she's a little bit later in her 40s, she might be like, if she's in like perimenopause, she might be like, I forget everything. Can't remember anything. My brain feels foggy all the time. You know, I'm moody all the time. And that may be related to her serotonin receptors and her need for serotonin because of the lack of estradiol. So, and I'm going to show you a slide in a little bit that'll make this make a little bit more sense, but as she's going through perimenopause and into menopause, estrogen, and in this case estradiol, is decreasing, but it's not decreasing like in a steady decline kind of rate. It's all over the place. It's up and down. And 1 month she might have a decent amount of estrogen, and another month not nearly as much. And so that's one of the reasons why her menopause symptoms may seemingly be all over the place. And they might change from month to month, even day to day. And she probably tells me she feels a little bit crazy because of it. Progesterone is the other hormone that we're talking a lot about when we're considering perimenopause. It's important, of course, to ovulation and menstruation, whereas estrogen is the proliferative hormone that helps the endometrial lining of the uterus thicken during the first half of the cycle. Progesterone is the hormone that keeps it nice and thick and kind of keeps it in place so that it can be there to catch and nourish a fertilized embryo that cycle, should that happen. If that doesn't happen, estrogen rises again, you shed the whole thing and start all over again. Some progesterone is actually made by the uterus itself and is made in the brain. And there's actually targets in the brain for progesterone, in the amygdala, the hippocampus, the frontal cortex. What are those places? They do mood and memory, among other things, right? So the amygdala, hippocampus are areas in our limbic system that have a lot to do with how we entrain memories and remember certain things. The frontal cortex up here, this is where a lot of our personality is. So if you feel like your mood and your personality is all over the place, that could be some of these progesterone shifts that are happening there. The adrenal glands, progesterones can be used to synthesize these neuroactive peptides. That's a whole different thing besides the progesterone. And those can actually cross into the brain and affect certain targets in the brain. So all of this to say, the progesterone can be really important for her brain health. Okay? One of the first things we see happen when her progesterone starts dropping is she doesn't sleep as well. So the areas of her brain that help regulate sleep-wake cycles, help her relax. It's a GABA agonist. GABA is our main inhibitory neurotransmitter in the brain. It's the one that acts like the brakes on everything. And so as her progesterone levels are dropping, she might be like, I lay in bed, I feel physically tired, but my brain just like won't shut up. It just keeps going and going and going. Or I'm so tired I can fall asleep, and then 3 o'clock in the morning, ding, I'm wide awake thinking about all the things that I need to get done for the day or that I forgot the day before. You know, those are some things she might tell me if her progesterone is decreasing and it's affecting her ability to sleep and stay asleep. Progesterone increases the basal metabolic rate. If you've ever done temperature checks to check your ovulation and your cycle, we know that there's a bump in our basal metabolic rate, our basal temperature right around ovulation, and it stays a little bit higher in the second half of our cycle. It downregulates estrogen receptors and induces enzymes that break down estrogen and metabolize it. Well, that makes sense, right? If estrogen is supposed to predominate in the first half of the cycle and progesterone is supposed to, sorry, did that come out? That might have came out too fast. If estrogen predominates in the first half of the cycle and progesterone is supposed to predominate in the second half, we don't want the estrogen blowing past the progesterone, so it needs to do some things to help support breaking down that estrogen so it can do its job. All right, and it also has ways that it helps increase bone mineral density. All right, so with that, let's talk about what is happening in perimenopause and what is perimenopause. So a lot of my folks come to me, I think there's like a little bit of a nomenclature issue, which is probably only an issue if you're trying to talk to your doctor about like what's going on with you, right? So rigidly we identify menopause as, or we define it, I would say, as more than 12 months without a period. Alright, so menopause is one of those things you basically like blow right past and look back and like, oh, there it was, kind of type thing. But you can be cycling and still have symptoms of menopause related to the hormones that are changing. And so because you're still cycling, we would technically call that perimenopause, okay? And those symptoms can start as early as 10 years prior to menopause. Average is 2 to 8, but it can be up to 10. The average age of menopause by an American woman is about 51 years old. So if we use that 10 years, 40, a woman can start experiencing perimenopausal symptoms due to hormone changes, right? So in the early stage, she'll start to have some of the other symptoms, but still be cycling regularly. So she might have some of the brain changes, some of the mood changes. She might start not sleeping as well or having trouble sleeping because her progesterone is decreasing. As the years go on, she might start having some hot flashes, which might be a little bit concerning. She's like, I'm still cycling, why am I getting some hot flashes? And it just happens to be, what did estrogen do that month, that cycle, right? As perimenopause progresses and she gets closer to actual menopause, she'll start to skip periods. Maybe it goes 60 days before period, in between periods, and then maybe 3 to 4 months in between periods. And eventually the time will lengthen in between cycles that a year will pass, she hasn't had a cycle, and she's now officially postmenopausal. All right? So some of the things that define perimenopause from a medical perspective, FSH and LH are increased. So again, those are pituitary hormones, follicle stimulating hormone, and luteinizing hormone. Those come from the brain and talk down to the ovaries about developing a follicle for that particular cycle. FSH predominates in the first half when estrogen is higher, tells the follicle to develop. After ovulation, LH takes over and causes progesterone to be secreted from the corpus luteum, and progesterone does what it does, etc. As we advance through perimenopause and into menopause, the brain is just getting feedback that the ovaries aren't doing what they should be doing, and so it just starts screaming down louder to them, like, hey, do your thing. And the ovaries are like, we're tired, boss, we're done. All right, so they're not listening. So the brain is screaming at them, and so FSH and LH will stay high in a postmenopausal woman pretty much for the rest of her life, okay? So that's important to note, because in a woman who has stopped cycling for a different reason, she's had a hysterectomy, maybe she's on a form of birth control that suppressed her period, and she's in that like late 40s, early 50s time frame, and she's like, am I menopausal? I don't know. I haven't had a period because of these reasons in a while. We can do a blood test and we can check her FSH and her LH. So if those are high and her estradiol is low, she's technically in menopause, okay? The other thing that we'll also see is something called anti-Mullerian hormone will be decreased. That hormone is a measure of ovarian reserve. I tell patients all the time, like, a lot of times you'll see that used if a woman's going to try for IVF. They want to know how healthy her ovaries are. Can they harvest enough eggs from them? If they give her a fertility medication like Clomid. So they'll run this anti-Mullerian hormone to see if it's high enough for doing IVF. It will decrease as she gets closer to menopause. So that anti-Mullerian hormone is a measure of that ovarian reserve. Again, the next slide I think will illustrate it and it'll make a little bit more sense. But her progesterone will have been gradually decreasing, probably through most of her 40s. And then somewhere in the mid to late 40s, it'll make a steeper curve towards rock bottom, okay? And that's pretty much the path that progesterone will take. Meanwhile, while progesterone is doing that, estrogen is going to be decreasing, but it's going to be up and down all over the place, okay? As the estrogen decreases, she might experience some other symptoms of perimenopause, like vaginal walls thinning, more vaginal dryness. She might experience more pain or discomfort with sexual intercourse. She may be more prone to vaginal infections too because of the thinning of the wall that's happening. So those can be also some signs that estrogen is on the decrease. Both of those hormones too, as they decrease, they can cause a whole bunch of other things. Like they can cause and induce increased intestinal permeability, leaky gut, okay? Just by those hormones dropping, okay? So she starts telling me she's having more bloating, more digestive symptoms. Her bowels aren't working like they used to. She's never had digestive problems like that before. I might say, like, okay, we need to look at what's going on with your gut. Do you have some leaky gut just because your hormones, right? So, like, yes, we would want to maybe do some, look at maybe some hormone replacement or some other support to bring those up. We also want to manage diet and some other factors so her gut works a whole heck of a lot better. She doesn't have inflammation coming from her gut. It's also pretty well documented too that as those hormones decrease, if a woman has had an episodic depression early in her life, she's much, much more likely to experience depression just from the lack of estrogen and progesterone hormones. Okay. So finally, as promised, my little graph here to make it make a little bit more sense. The blue line is progesterone, the pink line is estrogen. And so you can see that this is, early perimenopause, and she starts to lose some of the progesterone, and then there's a point where this is where we're going to start getting the sleep and the mood changes, okay? Meanwhile, now the cycles are getting irregular because estrogen is all over the place, all right? So that dive in progesterone has even started to happen even before her estrogen has started to drop in a way that's causing the more obvious symptoms. Okay, so she might be here and thinking, I don't know, I just can't sleep very well because I've got all this stress. Maybe I had too much caffeine today, etc. She might come up with a bunch of other reasons why she's not sleeping, and it's really some progesterone support that she needs. This is where the irregular cycles and a lot of the what we call vasomotor symptoms come in. That's the hot flashes, night sweats, the power surges. Have you not heard of the power surges? You never heard women call them power surges when they get a sweat and a hot flash? All right? And then eventually menopause, they will both be decreased, all right? It's not a hot flash, it's a power surge. All right. So I referenced this a little bit earlier. She still needs some estradiol for her brain, for her heart, for her bones, okay? That's going to become the job of the adrenal glands, all right? So the ovaries will continue to make some testosterone. We even though we're female, we do have some testosterone. We need it for muscle growth, helps with libido, does several other things, okay? That testosterone, the DHEA, and the androstenedione will be aromatized, so that's the enzyme, it's called aromatase, in the adipose tissue, and they'll be made in estrone and estradiol, okay? And 90% of her post-menopausal estrogen will come from adrenal DHEA. All right, 90% of what she's going to make post-menopausal. Think back to that hormone flow chart with the pregnenolone steal. If she's depending on DHEA to make her postmenopausal estradiol, and all of that DHEA has been pushed, has been robbed and depleted because it's been pushed towards progesterone and cortisol. How well do you think that's going to work out for her postmenopausally? All right. So I saw a female comedian many years ago who had this joke. It's always stuck with me. Why do they call it menopause? They should call it menostop because it doesn't pause, and pause implies it starts again. And it's interesting as I work with women in this phase of their life how many of them, something I'll frequently tell folks is all things being equal, you'll go through menopause at about the same age your mother did. And a lot of them will come to me and be like, I don't know when, either I don't have my mom anymore, she doesn't know, I don't know when she went, right? And I've sat across from a lot of women who are like, my mom doesn't even remember. You just didn't talk about it then. And there's been a real change and transition in the last several years. Women talking a whole lot more about what they're going through in terms of perimenopause and menopause. It's like this veil has been lifted. We're not suffering in silence anymore. I included this graphic because there's now a greeting card out here that you can send to another woman commiserating about what you're dealing with perimenopause. At least we get to WTF together. Text me at 4 a.m. I will be up, all right? Because her progesterone stinks, okay? Or she's having another hot flash and can't sleep, all right? So over 3/4 of women will experience hot flashes when they go through menopause. 65% will experience insomnia and disrupted sleep. Over half will experience libido or vaginal dryness issues. A little more than a third of women will experience depression or anxiety and irritability or some combination of the above. So most of us will get to deal with this at some point in our life. Like statistically, it'll happen. And luckily we don't have to just like grin and bear it and just try and get through it anymore. And it's a good thing that we don't, because there are real risks for women postmenopausally. That lack of estrogen can increase cardiovascular disease, it can increase diabetes risk, it increases, of course, risk of osteoporosis. We talked about the bone health thing, weight gain, gallbladder disease, arthralgias, arthropathies. That's basically like those tricky bones that keep you up, bone pain, musculoskeletal pain, depression, anxiety, insomnia, okay? So with a woman who is losing some of these hormones, we have reasons for maybe supporting her with replacement hormone that don't have anything to do with, we're not supporting at levels that are going to regain her fertility. She's not going to start ovulating and potentially become pregnant anymore. But we do want to help support her brain health, her bone health, her heart health, right? You get to live a good life after you stop cycling, okay? So she comes into me, and then one of the first things we're going to do is we're going to talk about some natural hormone help, right? So I'm going to do the first kind of basics before we go and we start talking about any sort of HRT type thing. Is like, are we doing the main things that we need to support all of our hormones? What's our diet doing? Is she getting enough protein in her daily nutriment that will help keep her blood sugar levels stable, will help her keep her muscle mass? Is she getting enough fibrous veggies, okay? Our liver is what breaks down and helps metabolize a bunch of our hormones. And then after our liver processes them, they get brought into the large intestine to be, those metabolites to be excreted, right? So if the liver is compromised, it can, or not completely compromised, but if it's not up to the job as much as it should be, we might have some issues being able to get those metabolites of our hormones out of our body, okay? The other piece of it is we need to be eliminating regularly, all right? So going all the way back, this is why I wanted to check her thyroid before, because if her hypothyroid, if she has an underfunctioning thyroid, she might have constipation. She might not move her bowels that much because the bowel tissue is not getting the thyroid hormone it needs to do its job, all right? So I want to make sure she's being able to move her bowels from that perspective, and then we want to make sure there's plenty of fiber too that's helping move her bowels and helping those excretions come out so she can get rid of those metabolites of her estrogens, okay, and other hormones. We're going to talk about avoiding alcohol, right? One, it makes hot flashes worse, but two, it's also going to put more stress and strain on the liver who's trying to process these things out. So it's just not a really great idea to have alcohol in our diet regularly. It can also lead to situations where folks end up with more insulin resistance than what they think, depending on how many calories and some other things that are coming from it. So we'll have a big talk, like, yes, even that glass of wine that you think is helping you de-stress is probably creating a little bit more issue for you than maybe what you'd like. So maybe we can find other healthier ways of managing stress: yoga, deep breathing, journaling, walking, all that kind of stuff. And I know it's easier said than done. Mom, she's got kids, maybe job's stressful, who knows what's going on with the kids, maybe there's like a contentious thing with her husband right now, so like she might laugh when I say, hey, you need to manage stress. But we're gonna say, okay, we really need to do that. We're gonna, going back to cortisol, we're gonna put other things off and affect other things downstream if we're not really managing stress seriously. Okay? And then another one I will always talk to women about is exercise. And particularly because weight gain, how many hormones have we talked about weight gain being a potential side effect of that hormone being at? Thyroid, insulin, cortisol, estrogen, progesterone, so they all have a different way that she might be like, I just can't get these 15 pounds off. And I've been eating like I did 10, 20 years ago, and it won't budge. In fact, it went up. I don't know what else to cut out. I don't eat carbs. I don't eat this. All right. One of the things I'm going to talk to Molly about is her exercise. And primarily, especially women north of 40, but definitely 45, I'm going to emphasize strength training with them over cardio. All right, which is kind of a little bit of a new thing, because for a long time, we've been afraid of getting bulky. We don't want to have man shoulders and things like that, which is not possible. But strength training, okay, lifting heavy 2 to 3 times a week, gonna help her bone health. Okay, that extra increased resistance training is gonna give her musculoskeletal system the stimulus to grow stronger. It's something called Wolff's Law. It's gonna happen. So we're gonna insulate her from some osteoporosis with strength training. We're gonna increase her muscle mass, okay? This is the magic of maintaining your metabolism into your older years. Muscle mass is where your basal metabolic rate comes from. So the more lean muscle mass you have, the higher your metabolic rate is. That means the more calories you burn even at rest. So if you like eating food, if you're someone who the idea of restricting and eating little rabbit food meals to lose weight, you're I can't do that, then hit the gym and build some muscle, all right? And then you'll actually need more calories to build that muscle. Granted, it should be proteins and fibrous veggies, circling back up to the first one, but we'll be able to eat more calories, enjoy more food, have the strength, build that muscle mass that metabolizes that food. And I also love increased muscle mass for women as they age, because this is where your independence comes from, right? You just squat every time you get up off the toilet. You want to keep being able to do that. You want to keep staying in your home for a long period of time, being able to take care of yourself, maintaining your independence, playing with your grandkids, bringing in the big bags of cat food or dog food, right? You can do that when you have muscle, right? So anybody you love in your life will benefit, especially you will benefit from more muscle. So I'm a big fan of strength training. If you can't tell. All right. So once we go through all of that, and maybe Molly's okay, Bet, I'm on Instagram all the time. I hear all the people saying that. I've done all those things. I'm still having some issues. I need some more help. How do I dig in? Where do I start? Etc. So this is a time, once we've gone through some of those basics, this is a time where we might start talking about, is MHRT right for Molly? All right. She's a little younger. She's in her early 30s, but maybe in her 40s, we're going to talk about this. So the M is just menopausal HRT. We're just distinguishing it from other times where we might use HRT. It can be safe and effective for reducing symptoms, okay? There's a whole lot of misunderstanding about HRT, especially for women. There were some studies that were done back in the day that had some flaws to the design that led to a lot of women becoming very scared of doing HRT. Some of the problems with those studies were because they used synthetic estrogens, the bioidentical hormones, a lot safer for women, but they do involve having an individualized risk management program for each woman. What is your heart disease risk? Who's looking at your lipids and managing your cholesterol and all those things? Who's checking, do you have a family history of osteoporosis? Do we need to worry about osteoporosis for you because you have a certain build, or your mom was prone to it and your grandmother had it, and all those things? So depending on where the risk settles out for you depends on, whether or not you're a good candidate for HRT. If you have breast cancer risk or something like that, maybe not. We're going to have to see what kinds of breast cancers it was, how far back in the family, those sorts of things. That being said, the risk for developing breast cancer because of HRT is extremely low, right? All things being equal. So it's really actually fairly safe and effective. For Molly, if she's in her mid-40s, we might actually start with just progesterone-only replacement for her. She's still cycling, but remember my graphic where her progesterone has decreased first, right? So we might just use some progesterone with her, help her sleep a little bit better, and like mellow out her mood so she doesn't feel so irritable, right? We can do that while she's still cycling. We can either do it in the second half of her cycle, or we can do a slightly lower dose and just do it kind of continuously, depending on where she's at in her cycle and how well she responds to it. We can do estrogen or estradiol replacement. Usually we'll do that after the final menstrual period, so after that year without a period. You can do it while she's still cycling, but at the same time, towards the end, we're all over the place, right? 1 month estrogen's high, and the other month it's down here. And so it might be we're chasing a moving target all the time. It's really hard to find the right dose for Molly because it's changing all the time. So we might just be like, let's wait till we're all done and then we'll add this in here, okay? Now, if we're going to do HRT to help with bone health because she has a risk of osteoporosis, just know we do have a window in there that we have to get to it before replacement of estradiol is not going to help her bone health. I think it's 5 years. For some reason, my brain wants to say 2 to 5, but we want to do that a little bit sooner rather than later. So sometimes I work with women who are maybe in their late 50s, early 60s, and they're like, hey, I think I want to do HRT, and I'm sort of like, for what? And you know, if we're talking about bone health, I'm like, we kind of missed the window for that. And that's one of the downsides to like just sort of now having more of this conversation, and one of the reasons why we want to have this education for women so that they can have this conversation sooner rather than later with their healthcare provider once they go through menopause. You want to kind of, once you're a year without a period, you want to start having that conversation of, is HRT right? Am I a good candidate for me to help protect my bones? You can still do it after that time frame, and it's still helpful for heart health, for brain health, cardiovascular system, all right? It's just not necessarily going to be as helpful for osteoporosis at that point, all right? Dosing and administration needs to be individualized, so we always start with testing, right? We do labs that will look at serum, so what are your levels in your blood, because that's the gold standard for looking at hormone levels. Some hormones we can measure in the saliva. That's the free fraction of them. That's the amount that's not bound to hormones or to proteins. And then other ones, does everybody know about a Dutch test or a urine test for hormones? Okay, so we do that here. Dutch is dried urine for total comprehensive hormones, something along that line. And what that's looking at is the metabolites of the breakdown of estrogen as excreted through the urine. So that's kind of cool because we can see not just how much estrogen of the different estrogens, the estradiol, estrione, and estrone that you're making, but how they get metabolized. So the first pass metabolize, they get metabolized to certain OH metabolites, and then those OHs, the 2-OH, 4-OH, etc., they can actually bind back into the same receptors as estrogen, and some of them can actually be even more powerful in terms of how they bind to those estrogen receptors. So how we metabolize it, if it's not balanced properly, we could actually be having symptoms of too much estrogen from a metabolite, even though our estrogen levels are actually normal. So if we want to do like a really good deep dive in what's happening with her hormones, I am going to recommend that we do a Dutch test at some point so we understand how these things are being metabolized as well. That's one of those ones that, again, we want to hit in that like day 19 to 21 window if she's still cycling. If she's postmenopausal, we can do that really kind of anytime because they're kind of, you know, sort of here type thing. They're not all in flux throughout her cycle regarding each other. So it really starts with quality testing as we're coming to making a protocol that's going to be individualized to Molly and feed back into what she needs in her health journey. So, I think that is all that I had. Oh my gosh, did I talk that long?
That's a lot of information.
I'm so sorry. Thank you. Phone number here. So just as an adjunct to seeking assistance, this is the stuff that we work with kind of all the time here at our clinic. Any of the providers can. So even our male providers. Look at you, Dr. Dave. But we do have. Understand not everybody wants to maybe talk about lady stuff with everybody. But hormones and helping women look at a total picture of what's going on with their hormones and finding holistic ways to help them and support them, and then potentially considering HRT is something that we do here pretty routinely. So if that's something that is of interest, you feel like you need some more help, or you're looking for support with, or you have a friend, a mother, a loved one, somebody else who needs that kind of support, you can always give us a call, and we can work with you on that. So with that, I'll open it to any questions if people have some.
I have a question.
Yeah.
Excuse me, can you speak to TPO and how that plays into all the other thyroid hormones?
Thyroid peroxidase antibodies?
Mm-hmm.
Yeah. So that's actually an enzyme in the thyroid that takes the thyroxine and puts iodine on it. Okay? And it's not a hormone per se, it can be a target for the immune system when we have autoimmune thyroid. Okay, so if somebody has a Hashimoto's or an autoimmune thyroid, their immune system is mistaking their thyroid for foreign tissue and is activating an immune response to it, and TPO will be the target. So that is usually indicative of Hashimoto's autoimmune thyroiditis. So part of my full thyroid panel for Molly would probably be to include TPO antibodies and maybe even thyroglobulin antibodies to see if there is a autoimmune reaction to her thyroid gland. She could be having autoimmune attacks to her thyroid for years before her TSH or T4 start to drop. Okay? So it's not uncommon for me to see a woman in her 20s or 30s have those antibodies, but still have plenty of T4, TSH normal levels. Okay, and when I'm working with her, I'm saying if we get rid of gluten, which drives the TPO antibodies, we can preserve your thyroid tissue for a lot longer than if we don't do anything about this now. If we don't take gluten and some other irritants out of the diet that are driving the TPO antibodies, this will come back to roost at some point when you lose thyroid tissue, and now you can't make enough of your own T4, so we have to give you replacement T4, probably for the rest of your life of some sort, because you've lost enough of the tissue that it can't make it on its own. Does that answer your question?
It does. Thank you.
I will be talking more about thyroids and autoimmunity to thyroids later this summer. I think big August, Monday, I'll be nerding out on thyroids. So come back to that one if you have some more questions. Like I said, we have some ones on cardiovascular health, cholesterol coming up, holistic addiction recovery, I think is the one that's going to be at the beginning of May. We'll be talking about metabolic health, gluten-free holidays. So the first Monday of every month, on our Instagram page, there is a full schedule. Of course, sign up for our email list, and you'll get those pushed out to you when we're having ones. So come back and join us for any other follow-up. Did you have some online questions?
No,
Okay,
nothing.
great. And I'll be around for a little bit if anybody wants to have aside questions. Yeah.
When you mentioned about we go through menopause around the same age as our mothers, and you said sometimes our mothers are no longer with us or whatever. I just